House Bill 1027 serves to protect young children and minors from decisions and therapies that have lifelong consequences, and they are certainly at a too young an age to make those meaningful decisions. It is about hormonal treatment of prepubertal minors to block or reverse their normal human development to puberty. At ages 8 to 14, these children are not able or ready to make decisions about choosing their gender, even if they are assisted by caring adults, medical professionals, and counselors. It is just too early to start a journey in medical interventions and lifelong physical, emotional, and psychological consequences. As the bill states, Section 1, Part B, standard medical practice does not involve prescribing hormone treatment for gender dystrophic or gender incongruent pubertal minors, except as provided in the subsequent section. So it is not standard medical treatment, and we are basically taking that fact and codifying it into House Bill through House Bill 1027. There have been previous guidelines by various professional societies that are being progressively changed and transgressed.
I am with the Pediatric Endocrine Division at Vanderbilt Children's Hospital. So my name is Dr. Cassie Brady. I'm a board-certified pediatrician and pediatric endocrinologist at the Monroe Carroll Jr. Children's Hospital at Vanderbilt. I'm the co-director of our multidisciplinary team providing care for transgender youth. I'm speaking today on behalf of my team, the transgender patients that we serve, the other medical providers across the state seeing these patients, and the patients' families they see. The care of transgender youth is complex. A great deal of care is taken at every step of the process to ensure the safety and welfare of the children and families we serve. Doctors and mental health providers adhere to extensively researched professional guidelines set forth by national and international specialty organizations, including the Endocrine Society, the American Academy of Pediatrics, the World Professional Association of Transgender Health, the American Psychological Association, and other organizations. Providers across this state utilize these guidelines when initiating affirming medical care for transgender youth. Decisions to begin hormone therapy are always informed by the current best practice guidelines and include input from mental health providers, other expert physicians on our teams, as well as by the individual parent and their caregivers. Detailed informed consent is obtained from the patient and guardians prior to starting any medical care, such as the puberty blockers or affirming hormone therapy. These treatments we provide are life-saving. Transgender youth are an increased risk for suicide. Nearly half consider it, and a third actually attempt it. When receiving gender-affirming care, suicide risk declines, and these individuals live longer, healthier lives. We base our hormone treatment or our pubertal blocking treatments on age. We base it on Tanner stage pubertal development, and that's based on physical exam and laboratory findings. And puberty can start as early as 8 in girls and as early as 9 in boys and be completely normal. These hormone treatments are used already in precocious or early puberty and are completely reversible, safe medications that have been used for many years. No other standards of care that I use are put into code. I use standards of care for my diabetes patients and my Turner syndrome patients and all of the other endocrine patients I see, and I'm not sitting in front of a group testifying for those standards of care. To get to Tanner 2, there's a specific laboratory value for the brain hormones, as well as the gonadal hormones, the testosterone and estrogen. And we have physical exam findings that key us in that Tanner 2 is developed. Average age of puberty is around 12, but like I said, normal puberty can begin at 8 for a little girl and for those born girl, and at 9. Once that mental health provider has made their assessment and written me a very formal assessment and letter, and parents have provided informed consent, the child is in Tanner stage 2 development, and I've met with them and agree, then we move forward. So the mental health care provider must have certification in either licensed clinical social work or psychology or psychiatry. Usually we do not use psychiatrists, but we will use psychologists and therapists that are licensed and experienced in gender affirming care. So it's not just anyone, and we have an extensive list of individuals we'll use and interact with. It requires specific sessions with them, and they use the DSM-5, which is a diagnostic textbook for diagnoses. And we don't necessarily like to say that if you're transgender, you have a diagnosis, but we still are reverting to using the DSM-5 for diagnosing gender dysphoria in order to make it to get hormone therapy. And there should not be any other kind of complicating psychological concerns at the time. Granted, these individuals can be depressed and anxious and other things, but that should not be clouding the picture in any way.
My name is Allie Chapman. I'm here as a concerned Tennessee citizen, constituent of Representative Manis, and a mother of a transgender son, to speak in opposition of HB 1027 or any amended version that may prevent, remove, or interrupt life-saving health care. Just like every other transgender person, there are some here. My son is not mistaken, he is not confused, and he is not deviant. It is so challenging for me to sit and hear the debate and the discussion around human beings in this way, but I don't think there's a recognition that by having these debates and breaking down people into pubertal stages and codes, that there's a missing element, which is this human. I can say that the CDC actually reports that LGBTQ youth are 4 times more likely to attempt suicide than the general population. And that the Trevor Project actually has found that one of these youth attempts suicide every 45 seconds. So we're already tallying quite a few here in this moment. There are already a host of other bills and laws that restrict our children in classrooms and clubs, sports, textbooks, school restroom use, and access to mental health care. But at its core, this bill reaches into the home, the most sacred space for parents and caregivers, families and children. And this intrusion adds yet another barrier where one isn't welcome, needed, or helpful. My son, Fox Schweiger, is now a young adult and recently testified in opposition to this bill's companion, SB 126. He highlighted the many barriers that our family faced to access, coordinate, and maintain the continuity of life-saving care that he needed. Our family relied on trusted advisors, therapists, medical and mental health providers, and we were all guided by the best practices that are shown to protect and benefit children, specifically transgender children. Unfortunately, we also found culturally competent nurses, doctors, dentists, specialists, therapists, psychologists, and other types of healthcare providers that are skilled to care for transgendered kids are rarities. We quickly learned that even the best health insurance offers limited to no coverage for some of the necessary services and treatments, straining our budget by many thousands of dollars. The cost alone of the specialized healthcare is an insurmountable barrier for many families. We measured and considered every benefit and every consequence. There were no flippant decisions. We did everything possible to support him because it was the right and most loving thing we could do, and because we wanted our child to survive and not die at the most basic level. I do want to say that the phrase social issues keeps coming up when referring to Tennessee's LGBTQ-related legislation. How every child exists in all of their identities, including the color of their skin, their ethnicity, their origins, religions, and abilities, is not a social issue, but the way that we choose to talk about, treat, and legislate against them is a social issue. Transgender children aren't broken, but the constant debate, their dissection, and the persistent harmful language will break them. It is not hyperbole that we will lose them. They will die.
I oppose this legislation because it creates new standards of legislative interference with physicians and parents as they deal with some of the most complex and sensitive matters concerning our youth. It is undisputed that the number of minors who struggle with these medical conditions is extremely small, but they too deserve the guiding hand of their parents, and the counseling of medical specialists in making the best decision for their medical and individual needs. While in some instances the state must act to protect life, the state should not presume to jump in the middle of every medical, human, and ethical issue. This would be and is a vast government overreach.
If any of you, if your children, if you knew your child or your grandchild had a 50% chance of thinking about suicide, or if your child or grandchild had a 3% chance of trying it, you would not be having this debate or bringing this legislation. Because this very discussion and putting this in the headlines repeatedly is what's leading to this. It's the stigmatization. It's the discrimination.